Good morning. Welcome to this morning session. Our first speaker for this session is Dr. Pranay Oza. He is going to be talking about hybrid Ecmo. Dr. Pranay Oza, please. He's been introduced before, but let me say a few sort of personal additions to what he has done. He started as a perfusionist, and he was very, very interested in extracorporeal membrane oxygenation, and this is 2009. And at that time, I was the chairperson for the Delhi Critical Care Society, and we talked about it as to, you know, how we take this further, how we take this technology further. And he's one man who has single-handedly started the Ecmo transport program, where he would go with his team to different hospitals all over India, wherever there was either a cardiac or cardiorespiratory or respiratory condition, and actually put the patient on Ecmo and stay with his team for at least 3 to 4 days until the team took over for the further management. And this is how we started. And look where it has come. Dr. Venkat Goyal, Dr. Pranay Oza combined their efforts, made a Ecmo Society of India, which only had 3 or 4 of us, you know, and this is 2009. And then we keep going, and now look where we have come, how many people have joined, and not for just nothing, but we have results in many centers that are doing Ecmo now, and most of all, in a resource-limited country like India, and which is heavily populated, it's particularly more challenging to get this technology across while continuing to trying to get the cost down. So cost effectiveness. And I think this is where Dr. Pranay, Dr. Venkat really have been the ground reality people over here who've been practicing this for a long time. And now this technology has really expanded to all these other institutions all over India. And I'm so pleased to see the society, the way it's coming along, and the way Indian people, children, adults with these critical illnesses are getting served, and we are seeing the outcomes, you know, really translated into reality, yet being cost effective. And I think for the youngsters who are interested in Ecmo, my strong recommendation would be to continue to look for innovation in this technology to make it cost effective, to find out low-cost alternatives of such components, disposables, so that we are able to actually bring it out in that kind of financial package so that it is available to not only people with very, very high expensive insurances, but people who need it and are of middle or lower middle class status. So I use this time just to sort of give my few cents worth, but here's the man himself, Dr. Pranay Oza, who's going to be talking about hybrid Ecmo.
So sorry for a delay. I'll be talking about hybrid Ecmo. So all of you know the different types of Ecmos. Basically, a main two types, VA and VV Ecmo. And then we have a hybrid Ecmos like VVA or VAV, and VV, VA or VVAV. And the variants of Ecmos like VVV, VVVA, and ECO2R or AVCO2R removal. Okay. Now, what are hybrid Ecmos? Basically, these are the modified form of Ecmo in which both the components of VA and VV are being handled. So you are involving we are giving a combined support to heart and lungs both, and they are the hybrid Ecmos. And the variants of Ecmos are the modes of Ecmos which remain same, and only the vascular extents are extra. So if you add one more drainage cannula, that is not a hybrid Ecmo. If you add one more return cannula, then it becomes an hybrid ECMO because you are supporting, you are doing both combined VA as well as VV ECMO, so it becomes a hybrid ECMO. And where if you, any ECMOs, if you require an additional drainage cannula, that remains as a variant of ECMO and not the hybrid ECMO. So what is VVA or VAV ECMO? They are hybrid ECMOs and both are same basically, but only thing that suppose you are on respiratory ECMO, VV ECMO, and then you require to switch over to the additional ECMO, then they label it as a VVA ECMO. And if you are on a VA ECMO and then you require to put a respiratory or a lung support, then it becomes a VAV ECMO. In fact, the name VVA becomes little confusing because then it becomes, there are two drainage cannula also and there is one return cannula. So it basically V-VA ECMO versus V-AV ECMO. That's a one drainage cannula and return cannula is in the both artery as well as in the vein. Okay. And then you have VVA or VVAV. Here basically what happens is the same as VAV ECMO, but then you require two drainage cannula. You are not able to get enough drainage, so you require to put an additional drainage cannula. So it becomes two additional cannula for drainage, both VV, and then return are two in venous as well as in the artery. And if it's basically respiratory and then switch over to the cardiac support, then becomes VA. And or if it's basically a cardiac support and then you require to put additional respiratory support, then becomes AV. And there are few other hybrid procedures that might require during the ECMO runs. Okay. That is when the patient is on VV ECMO and then you require to do some atrial septostomy for pulmonary patient developing severe pulmonary hypertension. So in that case, you might require, you either do a VAV or you can do just an atrial septostomy, and then that even your VV ECMO will be fine because then you are able to divert the blood from RA to LA, okay, by doing atrial septostomy. Or then VV ECMO with a transeptal return of LA blood, okay, in case of severe pulmonary hypertension. These are basically being done procedures when the patient is of long-term respiratory support and they are a case of end-stage lung disease waiting for a transplant and they develop severe pulmonary hypertension. And that time you can think about these all options that you can do it. So these are the variants of this ECMO, VV ECMO. For that you have to put additional drains, so draining the blood. So you are draining the blood from the jugular vein, draining the blood from the femoral vein, and returning back the blood to the RA. And this is usually be done when there is a high recirculation or the drainage flow is not adequate. So this will decrease the recirculation because we are draining the blood both from SVC as well as IVC and returning back to the RA. And VVA, again, when there is not adequate drainage because of your cannula size, either is small or you require too high a flow, then you require two drainage from the vein, two veins, and return to the artery. That is VVA ECMO. Now, what are the indications we think of a hybrid ECMO or VAV ECMO? Basically, it requires, there are three indications. It requires combined support from initiation. So when your patient is there, like as I told you, it's in septic shock or septic myocarditis along with an ARDS, you can think of putting the patient on directly on VAV ECMO. Second indication is when your patient is on VV ECMO and they require some cardiac supports. So in that case, now patient is on VV ECMO, but his hemodynamics are not stable, and then you require to put an additional cannula, then it becomes VAV ECMO. Or then when the patient is on VA ECMO and they require some, because the lungs are also not doing well, or there's a north-south syndrome, and then in that case required to put additional cannula, and then it becomes VAV ECMO. So combined support from initiation, as I told you, is in septic shock with ARDS, severe ARDS with inotropic score more than 100, you can think of putting the patient on VAV ECMO straight away. And myocarditis with ARDS, again viral myocarditis like in case of H1N1 or dengue with severe ARDS, you have to put the patient on VAV ECMO. The reason basically here is the cardiac contractibility will not be that bad. So in that case, these are the patients who are likely to go into have a more of a north-south syndrome, and that's the reason you have to think about putting the patient on VAV ECMO. When the patient is on VV ECMO and he develops cardiac arrest, so during ECMO, VV ECMO run, then you have to put an additional cannula to support the heart also, and then it becomes VAV ECMO. Okay. Or the patient when a VV ECMO becomes unstable hemodynamically, requiring higher supports, then you have to again switch over to a cardiac component also. Patient on VV ECMO, you are unable to support patient properly, and systemic perfusion is not adequate. Lactates are more than 8. Persistent metabolic acidosis in spite of being on VV ECMO. Then you have to switch from VV to VA. So you put an additional cannula and make it VA ECMO. And patients on VV ECMO deteriorating cardiac function like RV stunning or severe pulmonary hypertension or septic myocarditis. In that case, again, you have to put an additional cannula for the artery. Now, patients who have been primarily supported for heart, they are on VA ECMO and they require such additional support for respiratory, like in case of they develop some north-south syndrome or cardiac stunning is there. And one of the reasons for cardiac stunning is coronary hypoxia. So in that case, you have to put an additional cannula in the jugular vein to give a better oxygenated blood to the heart and the cerebrum or upper half of the body. And that is where we have to put an additional venous cannula. So what should be the vascular access for this kind of patients who requires VAV? Okay. Those patients who are, so the vascular access can be double lumen right IJV plus subclavian artery, double lumen right IJV plus femoral artery, femoral vein plus femoral artery and right IJV, or you can have again double lumen right IJV with femoral artery. It's a different combinations. So this double lumen right IJV plus subclavian artery is basically been done in the patients who are chronically lung disease and they are waiting for a transplant and they are on VV ECMO. And if they develop a severe pulmonary hypertension and they require some arterial support also, then usually they have been put on additional cannula and subclavian artery and then waiting for transplant, so they can still remain as a mobile and they don't have to be stuck to the bed completely. Double lumen IJV patient already on VV ECMO because of ARDS develop some cardiac complications, so septic and hemodynamic instability, and they require to put, these are the acute cases where they require to put on additional support. Then you can cannulate the femoral artery and give both VV plus VA support, because the combined support, and that can help you. But then again, these are the patient is going to be stuck to the bed, usually done for conversion from VV to VAV, and is a combined support from initiation is required. For vascular access for VAV, usually done for conversion from VA ECMO to patient is already on femoral VA ECMO, femoral vein and femoral artery, and you require additional support. So you put the line in the jugular vein. So you drain the blood from the femoral vein and return femoral vein has been drained and return is given to the femoral artery as well as to the IJV. Okay. And if you see from ELSO data, if you see the number of cases being supported with an VAV numbers, there are quite few cases you do require, but it's not that there are the only few anecdotal cases. There are quite a number of cases we have been supported with VAV ECMO. For a neonatal respiratory ECMO, there are almost 1,417 runs has been done, and the outcome remains consistent with around 60 to 70%. In pediatric respiratory ECMO, again, they have been done around 283 runs, total runs, and the survival rate is around 45%, which is almost going same as what your VV and VA ECMO. Again, in adults, 73 total runs has been done, and survival rate remains around 42%. These are all adult respiratory ECMOs where they required additional cardiac support, and they have been switched over to VAV ECMO. And these are the cardiac patients who required an additional venous support. From age group of 0 to 30, there are survivors for 40, total 275 runs. In 1 year, less than 1 year age group, 286 cases have been done with survival around 49%. From 1 year to 16 years, 68 cases and 55 survival rate. And in adults, 152, 32% is the survival rate. Okay. So these are our study, the type of ECMOs we have done, total 167. And out of that, the number of VAV which we have done is around 10 cases, survival is 4 out of 10, and the 40% is the survival. Out of 10 VAV, what we have done, 6 patients was for respiratory support. They required, the respiratory patient was being switched over from VB to VAV. Okay. And after the 2 survivors, the survival was 33%. And for a cardiac support, our 4 cases we have done, 2 survived and 2 didn't. So how will you manage VAV ECMO? It's going to be almost more or less same. Only thing, there are few points you need to keep in mind is, first thing is, how will you do VAVs? You have to connect Y connector in the returning way line and give one direct to the femoral artery and one will be going to the jugular vein. Okay. Now the one which is going to the jugular vein, it has to be partially clamped. That is the most important point you should always keep in mind. It has to be partially clamped. See here, it has been partially clamped. The reason is basically to adjust the flow, because the vein, the resistance is low. By default, most of the blood will go to the venous line and the arterial flow will be less. So you have to adjust both the flows. So in that case, you have to partially clamp the venous line and you have to adjust the clamp. And second thing is that you cannot keep the clamp the same place for a long time. You might have to change the clamp places. Or another thing you can use is you can use a screw and do a partial clamping. And second thing, the reason for this partial clamping is to compensate for the pressure difference in 2 outflow systems. Because it is going to VA and VV ECMO, and because the artery there is a resistance, so the pre-oxidative pressure and the post-oxidative pressure are going to remain high. So that with the high pressure, the blood will go to the vein. So if you partially clamp it, even though you can decrease the pressure which is going to the vein. Now, but what are the problems we encounter with managing VA ECMO is there's an increased risk of thromboembolic phenomena because of Y connector. So when there's a Y connector there's always an increased risk that there can be a turbulence and there can be a stagnation there and there can be a formation of blood clots there, and that can embolize either to artery or vein. If it gets embolized to vein, you are not much worried, but if it gets embolized to the artery, definitely that is a matter of concern. And second thing, usually most of the patients, they are on VV or VA ECMO, then you need to put an additional cannula. So that will, when patient is already on ECMO, heparinized, so that will be additional risk of bleeding that will be there. In VA ECMO, usually once the heart starts recovering, if it's a predominantly a lung disease and or a septic myocarditis or in that case, what you have to do is once the heart starts recovering, what we usually switch over is from VAV we switch over to VV ECMO as soon as possible, and usually that period is 3 to 5 days. We switch over from VAV to VV ECMO. You have to be mindful for the flow in both the sides, venous as well as arterial side. You have to be mindful that nobody removes that clamp from the venous side, so that otherwise most of the flow will go to the vein and suddenly the arterial flow will decrease and patient develops severe hypotension. So you have to be mindful about that. And because there is always a Y connector and there is chance of stagnation, you might have to target your acidity little on higher side. It depends what is your acidity target at that time. I'll definitely prefer to target acidity around 180 to 200 rather than 160 to 180. So in that case, you have to increase your target for acidity. That's it.
Any questions?
What are the chances of limb ischemia in VAV or any hybrid ECMO?
See, whenever you cannulate the femoral artery, okay, for any VA or VAV ECMO, we always put a distal perfusion cannula. So if you put distal perfusion cannula, the chances of ischemia is going to be much less. Except there is some embolic phenomena, then such story is different, but otherwise much less. Unless you if you don't put drainage distal perfusion cannula, then the chances are high.
But then the clamp, site of the clamp and changing the clamp or inadvertently releasing the clamp also will affect the limb ischemia, isn't it? Because the flow, arterial flow will be less.
Yeah, but when that is just for transient time when you are just changing it. By mistake, somebody opens it up completely and it forgets it, then there will be a problem, otherwise no.
Okay, and you mentioned about changing the site of cannulation, that is for thrombosis, local thrombosis?
Not cannulation, about
the clamping.
Yeah, no, because if the clamp remains in the same place for a long time, that will cause tube spallation necrosis. So that tube will get,
leak. Okay.
leak. So that's why you have to change the place.
Some cases we have used VA ECMO just with a PTFE graft without cannulating the artery, and in those cases we have noticed coronary hypoxia. I don't know if it's related to the graft because we are not cannulating; it's not going far into the artery. So is it going to cause that coronary hypoxia because it's just at the groin level? The blood flow is we have a competitive blood flow from up above. So,
Yeah.
and we in those cases when we have done VAV, they have recovered.
Yeah.
Is it really?
So it is basically more of a, see, whenever the heart starts recovering, the contractility improves, and that will not allow the retrograde flow of ECMO to come up.
So the graft will make a
And
difference then.
coronary is the last to get the ECMO flow because they are quite distant. So otherwise, even the heart contract is less. Unless the heart stops contracting completely or it's contracting very less, then only the coronary will get perfused with the ECMO flow. Otherwise, coronary usually doesn't get perfused with ECMO flow.
So you think that the graft versus the cannula, the graft is going to cause more coronary hypoxia?
Difficult to say, sir.
Okay, thank you.
The technical aspect. Instead of placing the clamp over the arterial cannula, you put the arterial cannula in VAV ECMO.
Yeah.
VAV ECMO.
Clamp has to be put on venous cannula.
Venous cannula.
Yeah.
So that you have
You
the
can restrict the flow to vein and increase the flow to the artery.
Yeah. What I am telling, can we reduce the size of the arterial cannula, tube, so that we'll have adequate flow?
Yes, you can do that, but the problem is that usually your intention is to switch over from VA to VV. So when you switch over from VA to VV, that time that cannula might be, you might feel that the cannula is small. You may not, see, those cases where suppose there's the ARDS with myocarditis, you plan to go for a VAV ECMO.
Okay.
In next 3 to 4 days or 5 days of time, the cardiac component is going to improve, but your respiratory component is going to take long time. So you can always easily get rid of cardiac, the arterial part of the cannula, and then it will remain as your standard VV ECMO.
Yeah.
So if you put a smaller size cannula, then
No, not
in that
cannula.
Tubings.
Tubings.
Yeah, then you
you
know-
can put a arterial, the connection, Y connection going from arterial side from the Y.
Yeah, understood. Understood.
Yes.
Or that will increase the resistance. That's it.
But the clamp is also increasing the resistance to the venous side.
Yeah.
Actually, in our case, we have done that. We use the cardioplegia line for the jugular. So the dialysis catheter in the jugular. So from the side port, we have taken a cardioplegia line and connected to the dialysis catheter here.
But
So
then see, other point is that how much does the flow will go with that?
I have seen a difference
Because
in
then
just 24
suppose you
hours.
require this is possible for a primarily VA ECMO and you just want to add and support lungs to some extent. But if it is a primarily in ARDS,
Yeah, that's true.
then this is not going to help because your flow which is going to go through a small tubes and small cannula will be much less. Yeah, north-south syndrome.
Yeah. For that I have
For
used.
north-south syndrome, it might help because
Yeah,
your lungs
that's-
are still functioning and working.
yeah.
But for a patient with severe ARDS, this is not going to be helpful to you.
Sometimes you just need to divert some blood from the venous side to the arterial side, not because if the patient has acute RV dilatation, like in that side, that condition also we can go for a VAV and divert some blood to the arterial side instead of letting whole
So
the cardiac output is going to.
In short, if I put it primarily VA ECMO and then you require VAV, then definitely
Okay.
you put a smaller size tube and that probably might work.
Yeah.
But if it's a primarily VV ECMO you require and you have to put an additional arterial component because of myocarditis or
Yeah.
something of that sort, in that case, you require more flow in vein and less flow in the artery. So in that case, this will not work. So in that case, you have to go for a
No,
proper
but
tubing.
main idea, even in you are putting for a patient has got a respiratory ECMO and the patient has got a myocarditis. The main idea of putting the patient to the arterial side is not to support the heart,
Unload
because
the heart.
offload the heart.
Unload that, yeah.
It is offload the heart. Okay, sir.
Just one.
So when you have switched over from VV to VAV ECMO, so do you reduce the flow to prevent the myocardial stunning? Because on VV you have at a very high flow.
See, that again we get guided by the targets. What is the saturation, what is the venous saturation. So basically it becomes a bit complex in that time because then we have to keep on adjusting venous flow and arterial flow and then total flow.
Okay.
So that will depend on how you are achieving the targets.
Okay, thank you.
Coming from the venous line, because even though you are putting a clamp, the pressure in the artery is very high because it will not allow the venous blood. So probably stasis is a possibility, even though there is a pump. But is there any way to measure it?
See, what we see, see is we have flow sensors. So what we do is we take the flow sensors, put it on the arterial side, and we see how much the flow is going to the artery. We put it on the venous side, and we see how much the flow is going to the vein. Okay. And then we keep it, so we see that different flows, okay, how much is the artery flow is receiving, how much is the vein is flowing.
No, it is both the inlets are there, because this Y connector is having one flow is coming from the artery, and one flow is coming
to the artery.
Yeah, going to the artery. No, it's see, Y line, one is from the femoral artery we are bringing inlets, two inlets are there.
Two outlets.
Two
outlets. We are not draining the blood.
Okay.
If we are draining, you require two drainage sites, then becomes a variants of ECMO. They are VVV and VVA.
Okay.
So are different. This is a hybrid ECMO where you are supporting both artery and vein.
What is your experience of VA ECMO in acute myocardial infarction? Any experience where you have done a primary PCI or a single surviving artery you have done VA ECMO?
See, we have almost done around 35 cases of VA ECMO. And out of that, at least around 25 was basically an ischemic heart disease primarily. And our survival is around 10 out of the 25.
I mean to say, like, somebody came with acute cardiogenic shock, you kept him on VA and then did angioplasty.
Most of them are on 25. Most of 25% are all ischemic with acute myocardial infarction with cardiogenic shock.
With intervention?
With interventions. Interventions in terms of plasty or even in terms of CABG.
And how many days you did you need a
Usually 5 to 7 days, maximum was 10 days.
I think in the interest of time, Richard has a last comment and then we move on.
Technical comment. Using a screw gate clamp is much easier than using
I said we can use that screw gate clamp or the clamp.
You may need to
just
get it
adjust the screw. That's
just very fine. It's much easier with that than a tubing clamp.
Yes, that was an ELSO data. I don't know. Probably Dr. Farmin will is better to answer that.
I don't see you'd ever need it.
ELSO data shows that. So I know, but then I have Dr. Pomani. You have any idea?
You just go to VA because you don't have the same issue.
You have any idea of VAV ECMO done on neonates? Because there are some data almost around.
ECMO in neonates itself has gone down. So, yeah.
We know arterial for most of the times because of the cannula problems. We don't have a suitable double lumen cannula for the neonatal age group. For that reason, we go for VA, either for respiratory reasons or for congenital diaphragmatic.
The nearest you get to it is if you do VV and the VV fails, instead of changing your cannula on the VV side, you just drain from both lumens of the double lumen onto the venous side. You don't do a combination trying to use the double lumen. You could in theory, but nobody does. All you do is you put a Y onto the venous cannula and drain from both lumens.
But because that has been mentioned on the ELSO statistics in neonates also.
All right. Thank you, Pranay, for this very interesting technical session. We move on to the next speaker, Dr. Sunil Puboni, who is going to be talking about transfusion while on ECMO. That's a very, very important topic, and you all know Sunil. He is currently the president of ECMO Society of India and has been president-elect SWAC also. Sunil.
Thanks, Praveen. Blood transfusion and blood product transfusion is a very important topic. We wanted to discuss about this again, though partly it was discussed in the training session because of the changing strategies, how it is affecting blood transfusion practices. There are various blood transfusion practices here, either giving either whole blood or packed red cells, cryoprecipitate, platelets, FFP as the usual ones. So majority of the institutions have ECMO protocol. It may vary slightly with a hemoglobin of 12 to 14 grams, platelets around 75,000 to 100,000 for microliter, and fibrinogen around 2 grams per liter. In cases of signs of spontaneous bleeding or bleeding on ECMO circuit, then we will try to increase these settings so that we can control the bleeding at that time. In neonates, as well as in children with less than 10 kilo weight, we use blood for circuit priming, but rest of the age groups we can use as a crystalloid priming. Hemoglobin is oxygen carrying molecule, so for maximizing the oxygen carrying capacity in situations of hypoxia or otherwise, predominantly the concept is to use hemoglobin because it is a colloid, so it is less likely to leak out of the capillaries even in the capillary leak stage. It is quite useful that way. So during the blood loss we use it also for volume supplementation. Products, sometimes they can cause dilutional problems, so one has to be vigilant about deciding what is the hemoglobin at that particular point of time. Circuit will get exposed to platelets, so till the circuit sites are adsorbed on, we may not get a steady state of platelets in the circulation. Similarly, packed red cells are used for bleeding and FFP cryo as and when needed. Blood products could be harmful because they come from human source in majority of situations, and transfusion reactions are likely as well, and the cost factor included as well. Whole blood, some regions of the world we use whole blood, including our own places here. It contains 45% of cellular components and nearly 55% of plasma, with an estimated hematocrit of around 55%, storage between 1 to 6. The problem 1 to 6 centigrade. The problems what I consider during this are if they contain white cells and if the whole blood is not a leukodepleted one, there is a possibility of sensitization and it might pose problems later on. From that point of view, packed red cells are advisable. In UK, for example, we don't use whole blood, but we always use packed red cells, which also mean they are leukodepleted. It contains the cellular component, and the estimated hematocrit is around 60%, and stored between 1 to 6 degrees centigrade, good for 3 weeks up to 5 weeks duration, can be extended up to 42 days, but the earlier the better. I do recall couple of situations where the patient has arrested, this was a neonate, as a result of blood transfusion probably with hyperkalemia in that. So, and a word of caution, it might be probably better to do a blood gas on the blood you are priming or you are infusing, so that you know potassium level in that blood which you are going to give as a bolus, but we'll be giving it very fast as well, so that would be another reason we need to be watchful of potassium content in that. They are functionally sensitive and limited resource as well. The whole blood transfusion, the hematocrit is around 30%. It can be given within 1 to 2 hours or sooner as well. It will increase hematocrit, that's hemoglobin, as well as clotting factors, and is also a source of volume. Adjustment in heparin dose is usually not required, but in case of massive transfusion, it is defined as defined transfusion of more than the circulating volume in 24 hours. That's in those cases, one has to be careful about calcium and other electrolytes as well in the patient. Leukoreduction filters are available that increases the cost of blood transfusion, but I found using the filters and reducing the white cell count load is very helpful for continuing later on. Fresh frozen plasma, one of the common agents used on ECMO circuits, especially when bleeding is a problem and the clotting products are abnormal in those cases. we can give 10 to 15 cc per kilo and then can repeat it again. Fibrinogen, monitoring it and trying to keep it between 1.5 and above is useful. Fall in the fibrinogen and rise in the fibrinogen, sometimes they're difficult to assess what is the reason due to. The fall could be due to clots in the circuit, consumptive coagulopathy, and the rise could be either as a result of hemoconcentration sometimes or as acute phase reactant that can go up as well. So usually many centers tend to maintain it above 1.5 grams per liter. The primary indication is for coagulation factor correction and also when the expected requirements, platelet counts tend to go down during ECMO either as a result of adsorption to the circuit or secondary to sepsis, bacterial or viral sepsis, more so in bacterial sepsis. From my point of view, it is still a debate at what level you would like to keep your platelets on. The worry is about intracerebral bleeds. In case of pediatric population, neonatal population, probably you can worry that you would like to keep it above 20,000, but the evidence is very much less about this. When I asked for opinion from different centers, Steve Conrad did mention that in their center they tend to keep around 40,000 and above 40,000 in a steady patient, not bleeding, they don't transfuse. If they are bleeding, obviously we all tend to transfuse them. Here we have single donor platelets and random platelets, but single donor platelets are more efficient. Antithrombin 3 replacement might be sometimes useful as it is described, especially when there is antithrombin 3 deficiency, your your heparin requirement goes up. So measuring antithrombin 3 when facilities are available is better. But in the recent international conferences, there was a lot of debate about giving antithrombin 3 or fresh frozen plasma just for the sake of replacing antithrombin 3. People have observed not much of difference in heparin requirement following this, and the advice at that time is heparin is a relatively short-lasting one, and economical wise, it is not such of an economical burden as well. So probably it is better to keep up to higher levels of heparin infusion rate than replacing with antithrombin 3. But still the opinion is divided at this point. Transfusion reactions, either febrile or non-febrile, are noticeable. TRALI can contribute to some extent. It stands for transfusion-related acute lung injury. Transfusion-associated infections have to be meticulously screened, like hepatitis C, hepatitis B, HIV, and CMV. This slide is showing about the frequency of transfusion reactions in one setting. Bacterial contamination can happen as well, so one has to be very, very careful about that. Alloimmunization, as a result of that, transfusions can be associated with graft versus host disease later on. The interesting fact is about how, at what level you would like to keep your patients with respect to their hemoglobin. Though the initial studies were recommending around 12 grams to 14 grams per deciliter, but actually this might hold good when the patient is hypoxic and in the initial phase of starting ECMO, but later on in a stable patient awaiting recovery or close to recovery, if their surrogates of tissue oxygenation are adequate, probably they can cope with 7 grams or 8 grams per deciliter as well. So caution is required in interpreting what is the right level for that patient on that particular day at that time. So we can advise you regarding that change in recommendation, but you have to think about it from time to time about the requirements of your patient. Similarly, platelets as well. At the Krishna Institute of Medical Sciences, we tend to keep around 40,000. If it is less than 40,000, then we transfuse if they are not bleeding. But otherwise, we tend to keep it above 40,000 and plus. Thank you very much for patient listening. Any questions, I'm happy to answer. Look for what is the reason for that acidosis. I presume you're talking about metabolic acidosis here, is that right?
Yes, sir. When we are having a packed cell unit,
Yeah.
Majority of the time we have seen that the packed cell unit is acidotic.
Right.
So when we do a ABG, just to look for hyperkalemia,
Yeah.
in that, like if there is acidosis, is there a way to correct acidosis before priming for the neonatal circuit?
Sure. Provided your potassium is okay, I presume. Yeah, with that. So I think it's a very good question because it depends on the blood volume of the patient. If it is a neonate, probably it might make some difference, and you have to be careful. Like once you give the blood transfusion, if you are giving it rapidly as well, you can do 1 or 2 blood gases during the procedure. And if the baby is manifesting with metabolic acidosis, then you can correct it. But if it is an adult where blood volume is huge, probably it may not make much of difference. So rather than proactively correcting the acidosis, my suggestion is to watch what the patient is doing, and if the patient's arterial blood gas are suggestive of reasonable metabolic acidosis, then we can correct that at that time. Given the time, that might get adjusted, but if it is severe enough, yes, you can correct it at that time. It all depends on the blood volume of the patient.
So do you stop heparin when the platelet is coming down?
We don't stop heparin, but we can adjust the dose accordingly at the level required.
Okay, because
for
also
the ACTs.
guidelines they have told
ACTs.
You don't require heparin when the platelet count is coming less than 1 lakh.
No, we don't do that. No, we don't do that. No.
So we are continuing heparin when the platelet
Yeah.
count is even less than 50,000. So
Yes, I think we do. Yeah. Okay. Because our range of ACT is quite narrow anyway, around 160 to 180. That's what we are advised for venous ECMO on that. So I will be cautious, but I don't necessarily stop heparin for that sake. I think majority of us will come across these situations when the platelet count is low, close to 50,000 around that, as a result of bacterial infections, not only rest of the
that's a
things.
dilemma kind of situation. We tend to stop heparin because when there is a chance of, you are expecting some chance of bleeding when the platelet is less than 50,000. It is not very, it's a dark area where to give heparin or...
Yeah, exactly. And that is a very good question because there is no evidence. I mean, how much evidence is available? Like at platelet count of 20, somebody will bleed for sure. Or platelet count of 30.
They don't bleed usually.
Yes, exactly. Like we are treating ourselves.
Give platelets.
Rather, we are treating ourselves with that. Our conceptions. We are treating them than the patient.
Because what we dare is to that intracranial bleed.
Ideally,
other bleed you can manage, I think.
Yes.
But intracranial, the end of the game is there.
Yes.
Thank you.
Ideally, we need more evidence with respect to that, why we are sticking on to a particular number of either 40 or 20 on that. It is an empirical number which has been chosen based on a probability of a risk happening.
Yeah. Thank you.
See, I think we also have to worry about the other side of the risk of stopping heparin in causing thrombosis in the circuit, in the flow. So I think it's a balance, but I don't think there's a particular platelet number that at which you will say, I'm going to stop heparin? 100, 80,000, 50,000 happens all the time on these patients where we continue heparin as long as you're monitoring ACTs.
Yeah, because we once we started sending this HIT also when the platelet count is otherwise coming down in absence of clinical bacterial sepsis. So we have started sending also that HIT thing, because on continuous heparin that can be one cause where the platelet is coming down.
Which circuits do you use?
We always try to use that heparin coated circuit.
Yeah.
Because we don't use our own circuits until unless there is a severe financial issues.
Sure. So this
and because I don't use I don't practice pediatric neonatal ECMO. It's an adult thing.
Yeah. So this comment is mainly how long you can use a circuit for on a high flow if it is heparin bounded, irrespective of, even if you stop heparin, my understanding is around 5 to 7 days it tend to run.
Even less than that. Even less than that.
Yeah.
Because that's the reason why heparin bonded circuits haven't gained the popularity that they should have, that you could actually get rid of heparin, but that's not true. Because most of the centers where they are using it, it's good enough for the first 3 days or at the most 4 days, and then after that,
Richard?
As soon as you put albumin in the circuit, your coating's coated. So it's a waste of time and a waste of money, frankly. If you albumin prime a circuit, you will, in any case, cover your coating. And you find that, for instance, when you talk about stopping heparin in a circuit that's been running for some time, if you use a sensitive assay of heparin, you'll find that heparin is coming out of the circuit into the patient for about 4 or 5 days, because it's coming off the plasma proteins that are coating your plastic. The other thing I'd just like to throw in the mix, because probably not many people have seen it, we used to see it more in the old days, is that in ECMO patients there's two types of DIC. You've got DIC which goes on in the patient. You can also get DIC that goes on in the circuit. So you can have a partially clotted oxygenator and you get the hematological picture of DIC, which is only happening in the circuit, and you can correct by changing the circuit. So if you start running low platelet circuits with no heparin, you'll find that's what you'll get. Your platelet count will go even lower, and you'll end up with fibrinolysis being released from your circuit. So, it's something you don't see very often with these polymethyl pentene things, but with the old Cymeds, we used to see it on an irregular basis. But you get the clinical picture in the lab of DIC, but actually none of the clots in the patient, it's all in your circuit.
So mild systemic inflammatory reaction can start after that as well, but it is probably a tolerable one compared to allow the disseminant intravascular coagulation to go on.
Tolerable thrombocytopenia happens because we tend to feel whether this will come down below 50,000 or 20,000, that can cause bleed or not. For a
See, I think the point that he's trying to make is that when you are on continuous heparin, you should think about heparin-induced thrombocytopenia and be aware of it, that if that is the reason that we should be sending that's what you were meaning, right?
Well, it is something happening constantly. You
need to be aware of it.
Remaining low. But again, in our setup, there is a dilemma. Is it secondary to the infection, as we always suspect infection, plus is it a heparin-induced thrombocytopenia? My response to that yesterday was, it is a rare phenomena. It doesn't happen very usually. In our incidence at Leicester, from our incidence, Leicester is like around 150 cases. We might probably come out with 1 or 2 cases per year. So it is around 1% or 2% in that. We might probably diagnose heparin-induced thrombocytopenia quite lightly, but there are very stringent criteria for diagnosing HIT. Once they pass all those criteria, then only we can diagnose heparin-induced thrombocytopenia. Just one important thought, Arpan, for all the team here, once you go back, please check with your pathologist, what is the accuracy of diagnosis of either 50,000 or 20,000. My pathologist here at Kim's Hospital said it is plus minus 40,000. Yes,
And there is a big difference between this manual count and the machine count always.
Yeah.
So we take better that when manual count is higher, we take manual count, and when the machine count is higher, then machine count.
Whatever suits you.
Yeah.
All right. I think on that note, we'll call this session closed. Thank you, Sunil.
Thank you.
And we move on to the next session.
Thank you. Thank you, Dr. Richard, R.K. Jain sir, and thank you, Dr. Chilnani sir. Here we will move to next session, that is plenary session. For that, I would like to invite Dr. Krishna Kumar sir, cardiothoracic surgeon from KIMS Hospital, Dr. Nagarajan sir, cardiac anesthetist from KIMS Hospital, and Dr. Sunil Puboni sir, President of Ecmo Society of India. Please come on the dais to be a chairperson for next session.
Is this on?
I would like to give a brief introduction to Mark Ogino. Mark is the chair of neonatal division and Ecmo division at Nemos Children's Hospital, and he is also chair-elect for ELSO. It's a proud privilege for us to have Mark over here. Despite his busy schedule, he wanted to spend some time with us. That's what I like from Mark. Having known him for nearly a couple of years, he would like to get associated with all the international scenarios before he takes up the chair. Thank you, Mark, for coming to us.
Thank you, Dr. Sunil. Again, thank you for, I can't stand at the podium, so I'm going to walk around. Thank you for inviting me again. It's really quite an honor to be here, and I really enjoy traveling to many places to learn about how ECMO is done in different areas. It's quite fascinating. You know, yes, we know North America, but North America is just one of many chapters within ELSO. So I've been going around and really learning about what is available and what is not available and what's feasible globally. So before I go on, how many of you know what ELSO is? Who ELSO is? A few. Good. All right. So I won't waste my time here. So let's talk a little bit about ELSO. So just bear with me because it does say a family affair vision for SWOC ELSO. I'll get to that at the end, but before I can get to the vision, I really want to talk to you and try to help you understand what ELSO does. All right, so ELSO. Does everybody know who Dr. Bartlett is? I hope so, right? So Dr. Bartlett, he's the man that worked many, many years to figure out how to bring extracorporeal life support outside of the operating room and into the ICUs. So as everybody knows this story, he was in California when this baby was born with meconium aspiration. The mother was not a U.S. citizen, was born in Mexico, came, delivered, left the baby there, and the baby was named Esperanza by the nurses because that means hope. So this was the first baby that went on in 1975 by Dr. Bartlett, and this is her 21 years of age, and she's now, what, in her 40s? So this is Esperanza. So Esperanza really did start it, but here's really the timeline of what happened. This was Dr. Bartlett working in the lab. He was at UCI and then University of Michigan. There were some trials that were done. There's University of Michigan seminars. This is when a bunch of the scientists who were interested in ECMO started having a registry collecting data. And from that, they created a standard treatment plan. And from the development of the registry, ELSO, the Extracorporeal Life Support Organization, was born. So ELSO was born in 1989. And again, it came out from a group of scientists that were getting together to try to figure out what was going on. They focused on collecting data so that they could understand whether what they were doing in the ICUs was helping patients. And I think that was one of Dr. Bartlett's brilliances. He knew that he had this technique, but really he needed to show everybody that this technique worked. And even to this day, we're doing the same thing. So that we've established something in neonates, but I'm sure there's a lot of you and a lot of people in your home hospitals that have a lot of hesitation about using extracorporeal life support for cardiac or respiratory failure because there's very little data. Oh, am I done? No? They're changing it. Oh, they're changing it? Oh, okay. All right. That was a short talk. Anyway, so Dr. Bartlett shares. So this is a little bit of history. So this is the first meeting in 1989. Okay, and you can see this was a little paper, and this is the program that he had at the University of Michigan, and these are some of the people that were at that meeting and really started ELSO. And if you look at this, the list of names here, you've seen in the books all of these guys doing, some guys and ladies, doing some pretty amazing things to move neonatal ECMO forward. Here's a picture of everybody that gathered in 1989, and you know, Dr. Bartlett loves photographs, so what is it, every 25 years now we go to Michigan to regather. So recently, a few years ago, we had a 25th reunion, had this picture in the same place with a lot more people. All right, lots of words here, but this I think is really, really important to the vision for SWOC ELSO. There's a lot of words here, and I'll go over this again. But I just, you know, this really is our mission and vision for ELSO. What's our mission? It's to support institutions delivering extracorporeal life support through continuing education, guideline development, original research, publications, maintenance of comprehensive registry of patient data. So I'm going to get to that in a little bit. But what's our guiding principles? We want innovation, we want expertise, clinical support, and development of a community. All right? All of that is very, very important to what we do and all of the efforts that we support within ELSO. And what's our vision? We want to be the we want to be the organization that you turn to for education, training, research, and data management, right? So this is our mission and our vision. This is ELSO. So what has happened in ELSO? You can see as time has gone on, it was sort of flat, and then the H1N1 came along, and then instead of neonates, what happened? Went to the adult world. So a heck of a lot more adults. So what happened? A lot more cases started being performed, and now in 2016, there are 379 ELSO centers, and these ELSO centers report all of their patients, or we hope they report all of their patients to us so that we put them in a registry and we can collect data to do exactly what Dr. Bartlett and all those scientists early on tried to do, is to gather data so that we can prove to the community that what we're doing is worthwhile and has good outcomes. So in 2006, there were about a little over 9,000 cases reported. So those of you who didn't know what ELSO is, so ELSO is an organization. It was an organization started by Dr. Bartlett and some scientists. The original goal was to collect data. So, and that still remains one of our primary goals, is to collect data so that we know if we're doing a good job or not. But as time has gone on, you've seen our mission and vision change to include education, training, etc. So here we are in 2017. Each of these are a little dot, represents a ELSO center. You can see United States and Europe, but you can see here in SWOC ELSO region, AP ELSO, and Latin America. So these are all the institutions now. So what are these activities? Why am I going through this? Because why do we want to try to establish a partnership with the Ecmo Society of India and with SWOC ELSO? Because we have all of these activities that we feel that we can share with you to advance the care here. So we have the registry of ECMO cases. We have an annual scientific meeting. We're very much into developing initiatives that prove quality of care. We have practice guidelines. We have guidelines on specific practices that may not have data. We use subject matter experts like Ravi over there, Dr. Ravi from Boston Children's, who really has a lot of experience to give us some guidance. We expand education, and something else, we publish. We want to publish so that when you go back to your institution and your administrator says there's no data, you can pull out a paper and say, yes, there is data. So here are the outcomes. The overall outcomes, this is of July 2000. Remember, neonatal cases started in 1989. Adults probably started about, let's say, 10 years ago. All right. So what are each of these activities? The registry. This is probably the most important thing that we do. It's probably the most tedious thing that any member has to also do to be a part of ELSO, because we ask you every time you have an ECMO patient, we ask you to submit data to help collect outcome data, complications, and a ton of things. So currently, the registry is providing data, lots of numbers, but it's just raw data that's graphed. And Ravi, excuse me, I don't mean to be, Ravi was a registry guy, so, but Ravi did progress the registry forward, but we've gotten to be a little more sophisticated. So what's happening now, those of you that have submitted data, is we've gotten some new software and we've developed some new reports, and the registry will be very much more robust with data that is and graphics that will help you present this in a way that's a lot easier to understand. So the presentation is going to change, but what's also developed is this outcome reporter. Now, why is this important? Because the #1 call that ELSO gets is we have a 8-year-old, or let's say an 18-year-old who has respiratory failure from E. coli sepsis and has a cancer. Should we put that patient on, right? That's a common question. We need to know, because at our institution, have we seen this? No, we haven't seen this. But when you go to the database, you probably can pull 50 or 100 patients out to see what the outcome is. So this is coming online now. So if you're an ELSO member, you can pretty much put in, you want the age, the support type, the mode, and put in the diagnosis, push the button, and it will give you how many cases we had, how many cases in the last 5 years, what the reported survival is, what the reported survival in the last 5 years is, what the average length is. So this will help a lot of you who are doing ECMO to decide if your patient is somebody that should be put on, or at least you can give the family some statistics on whether you feel that the risk is what the risk-benefit ratio is. What's the other thing that's coming to the registry that's exciting is this collaboration with Arbormetrics. Now this will be introduced next year, but what this is again, before it was a presentation of data. Now we have a computer program that allows us to do statistical analysis and tell us whether trends are statistically significant or not. Why is this important to regions? Because before we couldn't really break it down into groups, but now you could do your hospital, the type of patient, the time period, your peer group. So if you do only 10 patients a year, you could put peer group that does 5 to 10 patients. And the other thing that's important is the trending interval. The one other field that we put in here recently is that we can look only at SWOC ELSO, or we can only look at Euro ELSO, or we can only look at a chapter, because again, we appreciate that what is available in North America may not be available in this region. So we're now allowing the database to be taken down and to be broken down into regions and to give you statistical analysis to help you understand what the outcomes are and what the rates of complications are in your region. Publications, again, important. Publications continue to increase. Where publications this year are 20 so far that have come out of the ELSO database. And why is this important? Again, so that you can go and talk to your colleagues and your administrators to help them understand why ECMO, even though it's a new procedure, is something that is something to be considered for treatment of your critically ill patients. Guidelines. Again, I get back to this. We don't have data for everything. We hopefully will have data in a few years, but what sometimes we still need to get some guidance. And what we do is use sort of our subject matter experts and people with tremendous experience to put guidelines together. So one of the, this is not on here, but one of the guidelines is about management of anticoagulation. It was very interesting to listen to the questions that were going on, because those are all very valid questions, because again, there's no real answer with the data that's available. But there's a guideline there that sort of reviews the data and the recommendations that are currently being given through ELSO. Another initiative, quality. All right, so I'm sure at all of your hospitals, there's an emphasis on quality. Why? Because good quality comes to equals better outcomes. But you don't want to reinvent a quality process. So ELSO has created a quality process that you can become involved in that looks at the systems, environmental factors, workforces, process, and families. But again, this is something that can be utilized at your hospital as you would apply for something called the Center of Excellence. All right. So this is the biggie, education. Why is it important? Because you have your teams, and I'm going to give a talk on education later, but somehow you have to be able to educate your teams, and this is extremely expensive. Why? Because you have to educate your teams in the beginning, but you have to have ongoing education after your initial one. So education can be a tremendous burden on any small program. So what we've been trying to do is come up with a way to help all centers so that each center does not have to come up with their own program. So we have different committees. Now what we're doing is standardizing the curriculum. So instead of everybody saying, what should we teach? We have a committee that determines what should be in a lecture, how long the lecture should be, and all the objectives. We use a lot of simulation. Again, we do simulation. We have now education courses. We have the standard training course, which is 4 days. We have specialized courses. We have workshops. The most exciting thing we have now is something called Collected Med, and I'll show you some pictures, which are e-learning platforms. So other new things that are coming down is course endorsement, and also certification of individuals, and soon certification of centers. So these are the projects. Soon to be released is an Ecmo 101 course, which is a very basic course that we think is going to pretty much be free to everybody. So nurses, residents, any new person that does not understand Ecmo can go to our website. It's created by an international faculty. It's online modules, and you just take this course, and at the end of it, there's a test. There's a course assessment tool that we are now developing so that we know that everybody's teaching the right thing, and then we have a written assessment tool. So again, all of these things are being developed so that we know what is being taught is correct, and we are making sure that the knowledge base at all of our ELSO centers meets a minimum. So here's Collected Med. This is an online module that will be out soon. We actually are using it. So the great thing is this is web-based, so it's available throughout the world. It's online modules. It's used to supplement our courses. We are developing standalone courses, and we're developing courses that are for education. The Red Book, If you guys haven't seen this, it's an 800-page book, which really goes into all of the different topics. We're now having a specialist training manual, and new thing that's coming up is we're developing monographs. I'm going to skip this. So now, international chapters. So in 2017, after all these chapters develop, you see a growth in ELSO centers in Latin America, here in India, in this SWAC-ELSO region, and Asia Pacific. So these chapters have brought in many more ECMO centers, and what's more important is hopefully we're bringing in more patients to enter into the registry to give better data. The current leaders for SWAC-ELSO is Malaika Mendona in the UAE, and Dr. Venkat Goya will be the next president in 2018 and 2017. I'm sorry, 2018 to 2019. Dr. Coombs is Europe, Dr. Chen is Taiwan, and Dr. Caneo is Brazil. So these are the chapters you saw. The current ELSO India centers, I have these listed. I have about, I think there were 14. But remember Dr. Sunil said there are 54 centers. This is very common throughout the world. We know that there are many, many other centers out there doing ECMO, but not reporting their data to ELSO. So our goal is to really reach out and try to find these other centers and try to encourage them to submit data to the registry. So I took this picture because this is about your ECMO Society of India, the conference. And one thing that struck me here was this. It says the critical care of tomorrow's world in resource-limited countries. And I thought that was very important because that really brings out the differences between North America, Europe, and Latin America, and this region of SWAC-ELSO, right? Because what are the challenges? It is really the resource limitations in your country. So in their first talk today, there was really a very good summary of what's been done here, but any institution that starts an ECMO program really has to develop and implement a program that addresses equipment, the facilities, the operational support, the human expertise, and define what their expectations are for their patients and the indications for their patients, and really look at the unique local populations. And we've been hearing a lot about that. And the one local indication that came to mind was the poisoning, of course, in this region. But when we look at indications and expectations, this is a local issue. It's not something that can be defined by ELSO. I mean, Dr. Furman gave you a very nice overview of indications for bridge to recovery, bridge to transplant. Hopefully you guys will not have bridge to nowhere, because that does happen, but you do have to figure out what your indications are and what your exclusions are, so you do not have a patient that ends up with a bridge to nowhere. Other resources, because this is where the resources come in. This is where you have to try to figure out how to meet the needs of the patient population, how you meet the needs of getting the patient population to access care, and how hospitals develop the resources needed to train their facility, train their faculty, and train their nurses, and train their other clinical staff. And you have to develop a business plan. So all of these things are things that have been addressed or have started to be at least identified by SWAC-ELSO to bring people together to answer these difficult questions. It's not something that ELSO, North America ELSO, can do, but we can probably, hopefully, help by sharing resources that will take some of the resource requirements, for example, training. So is this unique to India? And this is what I find fascinating. So back in the New England Journal of Medicine back in 2016, there was this really fascinating editorial. It's about equity versus equality. It's about resource allocation in Brazil. And if you read this, it's very similar to what I've learned here in India. So it's a global challenge, and we should use each other's experience on addressing how they overcame some of the challenges of limited resources. So one of the things that hopefully ELSO can do is connect people to others who have also been challenged by limited resources. So this was said earlier, and these are the things that really sort of struck me, especially what struck me was the number of people in the SWOC ELSO. I mean, that's a lot of people that are eligible, that can need extracorporeal life support. A lot has happened with SWOC ELSO. They've...
This was before adding Africa to this.
Okay.
These numbers, so now the numbers are more.
Yeah, so you got another billion. What's another billion? But so this is what Dr. Sunil was talking about. You're starting to establish the basic structure, but one of the things that I think is extremely important for SWOC ELSO is because of the number, it's important about sharing the experience and knowledge, again, to help others with the clinical management of patients. So what's my vision? What I would say is to continue to move forward and continue to build your list of achievements. And Dr. Sunil started talking about that. And I would, again, do the same thing that he recommended. 5 people with a passion and dedication that will allow you to overcome your challenges, because that will always occur. You have to have mutual cooperation within India and within the SWOC ELSO family to, again, help you with overcoming some of the resource limitations. Share the success stories to encourage the new centers, and share the clinical experience, the good and not so good, to build a collective knowledge. But what's most important for my vision is that you should reach out and call a friend and join the ELSO family. Why? Because it really comes down to our mission, right? So expertise. We want to bring the world leaders together to collaborate to figure out how to do this the best way. We want to have clinical support so that we maintain a comprehensive registry so you guys know whether you're doing the right thing or need to change what you're doing to meet the benchmarks in ELSO. And the last thing, which I think is extremely important, is that we want to build a community. You're fostering a communication collaboration between professionals. Because when you have these, I would love to be able to say, if you have poisoning, call India. They have the most experience. But if you have a patient with hematologic disorder, call Italy, because they have the most experience. So again, joining ELSO gives you all of the other resources, but I think the most important piece of ELSO is fostering the communication between the experts. So who are we? You have your leaders, but really, it's all of you guys. So ELSO is all of you guys, because you guys are the ones that are going to teach each other, and you're going to help people, not just in India or not just in SWOC ELSO, but throughout the world by sharing your information. All right. So thank you.
Thank you for the nice insight about the activities of ELSO, and I want to, any questions from that? And I want to know about the usage of electronics machines, that is Centrimag in India. Most of the centers, they are having now the centrifugal pumps. What is your experience about the Centrimag pumps that works on magnetic levitation? And
so my institution, we do pediatrics and neonates, and our sister hospital does adults. So at our pediatric hospital, we just only use Centrimag and PediMag. So we use Centrimag, PediMag for Ecmo, for VATS, for everything, and that's why we use it, because we use it both. So I've had experience with the Biomaticus, I've had experience with McCabe minor differences. The major difference is cost. The central bank is extremely expensive. But we have found that hemolysis. So what I was saying is we use the Centramag and the PD Mag for ECMO and for VADS, and that's the main reason we only use one device. So, and I have experience with the Biomedicus, the Rotaflow, the CardioHelp, et cetera, et cetera. There are minor differences. The big difference is cost, all right? But do we see, I think, do we see hemolysis? Yes. No, we don't see hemolysis with the Centramag. It's very different. The old Biomedicus, we used to see hemolysis all the time. Do we see a significant difference between the Rotaflow and the CardioHelp versus the Centramag? We see a little bit, but is it clinically significant? I haven't had that experience. I don't know if you guys, do you use Centramag? No? No. Yeah.
ECMO or the temporary RVAD support if required.
It almost works like LVAD, VADs.
Yeah. But after insertion of LVAD, some of them have.
For a long time.
Yes. I mean, it's used as a short-term therapy actually, but after the LVAD, some of them have right heart dysfunction due to the septal dysfunction due to the LVAD sucking of the pump and all that. Then they use it for a few days and then remove it. And then we don't need to reopen the chest. They use a graft and then pull out the cannula from outside. No, Dr. Richard might be.
Yeah, well, we use Centramag in the UK. We've also got Centramag in Sri Lanka. And it's a very, very good pump. There's no question about that. The heads work almost forever. We've tested them on the bench at 8 litres flow for a year. You switch it off and there's not a mark on the impeller. So these devices can be used for a very long time. They don't develop hemolysis late, so we've used heads for, they recommend for 28 days, that's what they're licensed for, but we've used them for 3, 4, 5 months. And you only change them because you're changing the whole circuit because the oxygenator's a bit tired. But in terms of the mechanics of it, they're superb. They're a single-use item, but in Sri Lanka we've been reusing the heads. So we plasma sterilize them, you could EO them. But judging how they work on the bench, it seems an enormous financial waste to take a $2,500 piece of kit, use it for 72 hours to support a neonate, and then throw it in the bin. Although they are licensed as single use, it seems in this context stupid to do that. The basic problem with Levitronics for ECMO is a philosophical and marketing problem with the company. If you know the history of it, Levitronics produced the pump as a Swiss company. They were then taken over St. Jude, which makes the artificial heart the HeartMate. So they bought it for VADing only. And they were selling the VAD circuits without an oxygenator for about $4,000. And nobody would buy an ECMO circuit that cost more than $2,500. So they then got in the situation, do we market it for just VADs or do we market it for ECMO? And before they resolved that in St. Jude, Abbott bought them. So they're still in the same sort of marketing dilemma. Do they market this device just for VAD or do they market it for ECMO? And the financial problems with it relate to that argument.
So Richard said everything, but I have to say, I don't think we've ever changed the circuit because of head failure. It's always been for oxygenator. And we can use a head for months. Thank you.
Thank you, Dr. Marcagino. I would like to request Dr. Sunil Pomoni, sir, to felicitate Dr. Marcagino with a book. And I would like to call Dr. Bhaskara, sir, on dais to felicitate Dr. Marcagino. I would like to Dr. Bhaskara sir to felicitate Dr. Lakshmi Raman.
Speaker is Dr. Lakshmi Raman on cerebral autoregulation on ECMO. Lakshmi has done phenomenal work. She is from Chennai. She says she spent 25 years in US now, and she is chair of ELSO as well as pediatric critical care at Dallas Children's Hospital. She has got increasing interest in the field of cerebral autoregulation and was really inspired by that. So here is the opportunity for Lakshmi to share her research and thoughts with us. Thanks, Lakshmi.
Maybe I'll use the For the past 2 days and all morning, we've heard a lot of clinical talk, and now you're going to really hear something that I've been working on. So switching gears and something very new. So the way when I started Ecmo, I can't claim that I've got a ton of experience. I've been doing it only for the last 10, 12 years. And so my clinical knowledge and clinical experience is not a ton, but what to me, Ecmo, the way I look at it is we have now, it's like cancer treatment. You know, initially people were figuring out how to treat cancer, and now people look at it more as how can we get the best outcome for cancer treatment. And that's how I view Ecmo. I think Bob Bartlett and all the pioneers spent a lot of energy trying to help us figure out this therapy, and now we do it so well. Now it's important, how are we, whatever we are saving, are we doing a good job of bringing them back to the society? And so I focus my interest in trying to figure this out. And so I'm going to share that work. So I have nothing to disclose. So in the next few minutes, I'm going to talk about neurological complications, neuromonitoring, and then the study that I have been working on in terms of cerebral autoregulation and neuroinflammation, and then where I'm going to take, hopefully, this research to the next level. So this, I think many of you have seen, this is the ELSO latest registry data. What I want to focus is the last numbers. This is the survival to ECLS. As you can see, the percentages in pediatrics and neonates, because most of my work is in pediatric and neonatal ECMO. But then, if they have brain injury, what happens? You can see that the percentage of survival comes down significantly. So really, that's causing a significant mortality. And this is the ELSO registry report. Now you get by yearly report. You can see really that these are the survival to percentage of complications, and then there's survival for CNS infarction and CNS hemorrhage. Really, we have not made an impact in the last several years. And anybody who can, who knows when they take care of a patient on ECMO, it's like a ticking time bomb. I mean, you don't know when this patient is going to develop a complication, and how are we going to avoid that? So what are the factors that put patients at risk for neurological complication? So we all know when these patients go on ECMO, they are really sick, they are hypoxic, they are hypoperfused, they are acidemic. And then you put them on ECMO, of course, you expose them to a lot of inflammation. You give them anticoagulation, you have a lot of microthrombi, you alter their intrinsic coagulation, and when you're on VA ECMO, there is loss of pulsatile flow, which can cause changes in cerebral blood flow and drainage. So how do we monitor these patients? Of course, if you're doing awake ECMO, that is the best because your patient clinical examination can tell you everything. But often, at least in pediatrics and neonatal ECMO, we don't have that luxury. Often these patients are sedated and intubated and sometimes even paralyzed. So then how do I monitor these patients? Of course, in neonatal ECMO, we've made it the standard of care. Most centers have made it the standard of care to do neonatal ultrasounds. And then EEG, only if many centers do it, only if there is a clinical indication. And then, of course, if they have an event, we then hike them down for a CT scan. And of course, there are a lot of small clinical studies where people have looked at using transcranial Dopplers, amplitude EEG. Then Mela Bambe's work has focused a lot on plasma biomarkers. So I'm just going to talk more about cerebral oximetry. I don't know, do centers in India use NIRS? Do you all use, yes, okay. So cerebral oximetry. So what do we, what is the principle? So here you have ultraviolet light that uses hemoglobin that is oxygenated versus deoxygenated, absorbs the light differently, and that is the principle that is used in cerebral oximetry. So here you have a superficial electrode and a deep electrode, and then it absorbs the light, and then you get a number that is you see on the monitor. So what do we know about cerebral oximetry in ECMO? So there are some neonatal studies that were done in the 90s. So let's say that the cerebral oximetry value came down, you increase the pump flow, you gave them PRBC transfusions, you tried to optimize everything, and then if the values came up, it was well and good. If the values didn't come up, then if you watched them for a little longer and then you took them down for imaging, they found that they had focal infarct or diffuse anoxic injury. And I think there are more studies now that have used it around eCPR scenarios. So there are, at least in the traumatic brain injury world and other scenarios, people have used cerebral oxygenation and correlation with mean arterial blood pressure as a surrogate marker for cerebral autoregulation. What do I mean by the term cerebral autoregulation? So it's an important hemodynamic response that helps to preserve the brain blood flow in the change of cerebral perfusion pressure. So your arterial vasculature changes diameter, thereby adjusts the blood flow. And we know when you have brain injury that there is failure of autoregulation, and failure of autoregulation is associated with poor outcomes, and we know that from particularly the traumatic brain injury world. So what do we know about cerebral autoregulation and in ECMO? I think these were some elegant studies done by Billy Short's group in the early 90s where they took neonatal lambs and cannulated them by veno-arterial ECMO and showed that when you were cannulated that your cerebral blood flow was significantly reduced compared to the control animals. So what can we do with this? I'm just going to shift gears and talk a little bit about the methodology that we use. So wavelet transform coherence, it's not a new methodology, it's been existing in physics for a very long time. And it is used to assess stationary or non-stationary signals. And in the clinical setting, it is used in the phase of non-stationary or dynamic signals. And coherence is a correlation between two dependent variables, and it is done over time. And there is a phase relationship, either in phase or anti-phase. So that is what we are going to use that principle. So people have used wavelet transform coherence to evaluate the spontaneous relationship. And in this case, the variables are going to be blood pressure and cerebral oxygenation. So this has been applied in neonatal HIE patients by the group that I'm working with in our own institution. And it has been shown even in a few years ago in Europe in Great Ormond Street on neonatal ECMO patients. So what is new with this that has been previously shown? We wanted to see if we can apply this dynamic relationship in cerebral autoregulation over time, and then we asked the question, can we use this to predict neurological events even before it happens? So this is I'm just going to walk you through this picture. It's a picture of a wavelet transform coherence. What I want you to look at is the colors. So when normally we say when your blood pressure fluctuates, you do not want your cerebral oxygenation to also fluctuate. We want it to remain constant. That is in the phase of intact autoregulation. So we don't want the two of them talking to each other. So we want them to be close to zero, so a lot of blue. But if your blood pressure swings up or down and your cerebral oxygenation swings along with it, then it means that they are talking to each other and they are correlating, and it is going to be closer to red. So there's going to be a lot of red. So these are two examples from Ecmo patients. A patient who had intact autoregulation. As you can see, there is a lot of this blue, and here we had a patient with neurological injury who developed multiple cerebral infarcts. And here, just to orient you, this is frequency and this is time of Ecmo in minutes. So our study aim was to evaluate cerebral autoregulation measurements and to correlate them with neuroimaging scoring, because that is a well-established way to measure now neurological injury. And so since ours is an experimental method, we wanted something that's already well-established to see if we can correlate that. What is the data that we obtained? We, of course, obtained clinical data. We got cerebral oximetry measurements, so minute-to-minute variation in cerebral oxygenation and blood pressure. And then neuroimaging. So neonatal patients got ultrasound, and of course if they had a neurological event and there was a clinical change, they got a CT scan during Ecmo. And in our institution for the past several years, we have made it to have post-Ecmo MRI as the standard of care. So I'm just going to walk you through a couple of examples. So this is a 80-year-old who was in a motor vehicle collision and then sustained multi-trauma. So she had liver, spleen laceration, and she had significant pulmonary contusion. So we were struggling with her with ARDS for the first 3-4 days, and then finally on the 5th day of her traumatic incident, we put her on Ecmo. So she had an initial CT as a part of her trauma workup, and that was negative. And then day 6 into her Ecmo run, she started having some pupillary changes, and then we took her down for a head CT, and this is what happened. She had massive intracerebral bleed. We actually emergently decannulated from her Ecmo. We did a decompressive craniectomy and ultimately saved her. But she was actually in my study, and we got some measurements for her. And so I just want to point out, this was about 12 hours. All this happened a few hours before her event, and we saw significant disturbance in her autoregulation. And as you can see, this is the mean arterial blood pressure on one side and the cerebral nares on the other side, and you can see the in-phase correlation. This is another patient. She's a 14-year-old patient, was a 14-year-old patient, unfortunately, who sustained meningococcal sepsis and was brought to our ICU and was placed on, emergently on VA ECMO on septic shock. And unfortunately, one day into her ECMO run, she had a significant change in her neurological exam. And she was also, we were getting measurements on her, and as you can see, she had significant disturbance in her cerebral autoregulation. Right from the beginning, she had disturbance, but this was very much around the time of her event. And you can see that there was big in-phase coherence that you can see between her cerebral oxygenation and mean arterial blood pressure. So we do these measurements, and we name it the autoregulation index. So we have now done that on about more than 50 patients, but we recently published half of the patient data. So our publication has about 25 patient data, of which 11 were neonates and 14 were pediatric patients ranging from 0 to 14 years of age. And this is the data that I have. So you can see that the cerebral autoregulation index, it is very reliable between this measurement of 8 to 32 minutes. This is the range where we can get this, and we found that they had significant in-phase coherence abnormality. And then we wanted to see what was the percentage if you had autoregulation index disturbance, what happened to their neuroimaging scoring. So we calculated that. So if you had an autoregulation index greater than 8% throughout your ECMO run, that seemed to correlate significantly with neuroimaging abnormalities. As you can see, there are a group of patients here who had pretty high neuroimaging scoring, but they did not have much abnormality in their autoregulation index. And of the 4 patients, 3 of them were cancer patients who had already significant changes in their brain imaging, and one of them was a neonate who was placed on ECMO for group B strep meningitis. So then we wanted to look at what are the things that can affect your autoregulation. Certainly we know big changes in PCO2 is something that can affect your cerebral blood flow. So we looked at the changes in PCO2 between pre-ECMO to post-ECMO and then correlated their autoregulation index, and we find that to be correlating pretty well. Because our patient numbers were small, we did not find that correlation either with pH or change in PaO2. Then we wanted to see, okay, we found this in ECMO, so we started doing these measurements in our sick children who come to the ICU but who are not on ECMO. So we have about 6 patients in the control arm, so to say these are sick children who are in the ICU, and this is our ECMO group. And we used a different method of doing these measurements using a CW6 instrument to look at their cerebral autoregulation, and we find, of course, ECMO has much more autoregulation disturbance compared to the control arm. So this is something that I'm continuing to work on, and I'm going to switch gears a little bit and talk about another project that we work on in terms of neuroinflammation. This project is being led by was done by my fellow, and as the pilot data is completed and we are getting ready to submit this for publication. So our hypothesis here is that ECMO causes inflammation, which can then disrupt your blood-brain barrier, which then releases myelin and neuronal antigens into the peripheral blood, which can then activate the lymphocytes and then cause antibodies, which can then go back into the brain and cause injury. So this is so what did we do? We took blood from our patients on day 1, day 3, and day 7, and then weekly if they were still on ECMO. And then we wanted to evaluate the serial adaptive and immune responses and also look at autoreactivity assays. So this is some of the preliminary data. So this is the cytokine data. This has been previously actually shown on ECMO by other groups. And this is our data where we looked at patients with brain injuries, this group, and without brain injury. And we saw an elevation in IL-5, IL-8, and IL-10 on all the days of ECMO. You can see that. This is actually a heat map. So if it is orange, it is negative, and if it is these colors, it is significant. Then we took the plasma of the ECMO patients and then took the peripheral mononuclear cells from healthy volunteers and then put those cells into the plasma of these patients from ECMO and see if they had a pro-inflammatory milieu, and that is what we find. So this is from the healthy autologous cells, this is the healthy heterologous cells, and this is the ECMO patients. And you can see particularly ECMO brain injury patients caused a pro-inflammatory milieu. So it seems like that their plasma sets forth an environment that can be pro-inflammatory. Then we also we found that there is activation of cytotoxic T and B cells in patients with ECMO, particularly those with brain injury. Finally, we wanted to look at the autoimmune assays to myelin and neuronal antigens. And here the brain injury patients are represented in triangles and the non-brain injury patients are represented in circles. And we find that brain injury patients had autoimmune responses to both B and T cells, to both myelin and neuronal antigens. And this is one of the patients that had this multifocal infarct. So we find that cerebral autoregulation was significantly disturbed on the first 3 days, and you can see that the myelin and autoimmune responses you have on different days of ECMO, and you can see day 1, day 3, and day 7. You can see on day 1 and day 3, the myelin and neuronal autoimmune responses were elevated compared to day 7, where we didn't have disturbance in autoregulation. And this patient also had inflammation and activation of the cytotoxic T cells. So in conclusion, what we are saying is that there is disturbance in cerebral autoregulation. The in-phase coherence seemed to be correlating with neuroimaging abnormalities. And maybe we can use this to help predict neurological events even before it happens. And ECMO also causes a unique inflammatory profile, and brain injury coincides with activation of all these cells and also causes autoreactivity. So our working hypothesis is that ECMO causes disturbance in cerebral autoregulation, which causes brain injury. Of course, we don't know if this is because of brain injury, they have disturbance in autoregulation, or disturbance in autoregulation causes this. It also causes inflammation, which can cause activation of the cytotoxic B and T cells, which by themselves can cause brain injury. We also think that ECMO causes disruption in blood-brain barrier, which can then activate the peripheral, blood can activate the peripheral lymphocytes, which can cause autoimmune responses going back into the brain, leading to more brain injury. So with this hypothesis, what are we working on? What we are now trying to do is that we are trying to measure, continue to measure in critically ill patients who are not on ECMO as well. And then we are trying to see if we can recruit the patients before they go on ECMO. Because if you think of sick children who are in the ICU but don't go on ECMO, you can potentially argue that their illness severity is not the same as patients who go on ECMO. So we want to see if we can recruit these patients prior to going on ECMO, which can be a potential challenge, but we are hoping to take on that challenge. And correlate these with neuroinflammation and autoreactivity, and also correlate with established biomarkers from previous study. And of course, I think where really the rubber hits the road is the long-term follow-up. You can have all this, but what does that mean in the long term? So we want to bring back these children. We already have an outpatient follow-up clinic, but we want to do this in a more comprehensive neurodevelopment assessment and also do some follow-up neuroimaging. Of course, finally, I would like to thank all the people who have made all this work possible. I work with a cerebral autoregulation team, a neuroinflammation team, and a neuroradiology team. And I couldn't have done without the funding from AHE, and also ELSO has supported me through this endeavor, and some of the Ms. And finally, last but certainly not the least, my ECMO patients and the family. And I'm happy to take any questions. Thank you.
Thank you, Dr. Lakshmi, for an excellent talk on neuroregulation and on ECMO, and especially a newer aspect of what you've been doing research on. I have one query on the wavelet transform coherence, what you're telling. You have highlighted about its ability to predict injury, but in terms of prevention, what steps you think would be taken once patient is already on an ECMO?
Yeah. I mean, no, those are very good points. Okay, so what if you find it? Are you ready to come off ECMO? I think that's always the challenge. But the other thing that we are working towards learning is the critical time period when they go on ECMO, when we change their pH from acidotic to normal pH, when we are going to rapidly change their PCO2, rapidly change their PaO2. Can we do anything in that treatment which can affect their cerebral autoregulation? That's the next steps that I'm working on. So we are hoping to recruit these patients pre-ECMO, try to get this data, and then post-ECMO in the first 24, 48 hours, try to get some hourly measurements and see if we can correlate with these changes. So can we propose the ideal management strategy when they go on ECMO? Because I think that is always the question, isn't it? You take these hypoxic ischemic patients and give them full flows, give them a lot of oxygen, bring down their CO2. Is that the right thing to do? I don't know the answer. And I think that is something we have to answer. And the other thing that I didn't show the data, that something that may be important is big fluctuations in blood pressure. That's also something that we find causes more disturbance in autoregulation. So is there a blood pressure target range for these patients? That is something that we have to think about.
So the other way is it, are you worried about the cerebral blood flow or this, or the perfusion pressure, which is, you think is the cause for the injury in these patients?
I mean, ultimately, whatever is the perfusion pressure, the ultimate, this one is the cerebral blood flow and oxygenation is the ultimate, this one, isn't it? What is the tissue really seeing is the most important thing. And yes, there are a lot of unanswered questions, but I think this is the first step to a big path that lays ahead. Yeah. And hopefully the granting agency will look into this and help me do the study.
Excuse me, madam.
Yes.
I have one question. Regarding NIRIS, it measures only the focal brain tissue oxygenation. What about the global hypoxemic, like jugular venous oxygen saturation?
No, those are very good points. Yes. So what we are working towards is another methodology called diffuse correlation spectroscopy. I didn't have any data to show that. And yes, you're absolutely right. Because the NIRS, we are actually monitoring only one side, and it is superficial tissues. What do you do to the deep tissues? So we are hoping to get that up and running in the next few months, where we'll be using diffuse correlation spectroscopy, where we can measure the microcirculation in all parts of the brain.
Right. Another question is, what about the serum markers, like cerebral brain injury markers measurement, especially in hemodynamic unstable patient, to correlate, is there any hypoxic brain injuries happening or not?
So that data, the plasma biomarkers, Mela Bombay has already published a lot of that data, and actually this afternoon there is another session on neuromonitoring, and I'm going to go over that data a little bit more.
Thank you very much.
And she's done that pretty well, yeah.
I think we'll end this session, and yeah, there's probably one more question.
Do you see an effect for pulsatility? Because in the 4-year follow-up data on the neonatal Ecmo trial, 19 out of the 20 normal children with completely normal scores all had VV. And obviously, if you go on VA, you tend to have a less pulsatile trace rather than normal pulsatile trace. Do you think there's an effect?
So we did not find either in terms of autoregulation disturbance or in terms of the neuroimaging abnormalities. We did not find a difference between VA and VV ECMO, which is quite contrary to the ELSO data. And so we did not find that. We tried to parse that out, and we parsed between neonatal and non-neonatal. We did not find any difference.
Can I have one more question, please?
Okay, last question.
Yeah, thanks for the wonderful talk.
Yeah.
Just to add a few points from experience. Whenever, as Dr. Mark Aguino said, we are still in the process of giving awareness to the people. So only we are called to initiate an ECMO when the patient is very sick and with the high PEEP and quite a lot of NORAD and adrenaline. So initially, when we started the ECMO, the BP will shoot up, and we lost some patients with the brain bleed. So nowadays, when we start the ECMO, we'll start with only 21% of oxygen, and without any gas flow, we'll start it, and then gradually increase. And one person have to stay with close to the inotropes to reduce it, so that there will not be any high blood pressure. That is one. Next thing is you are talking about neuroinflammation, other things. Like him, I'm also thinking how to prevent that. Maybe the situs of filters has any role, I don't know. Like situs of cytokine filters that you can add to the ECMO circuit.
Yeah, I mean,
I can absorb some cytokines, and if it is going to be, I don't know, like, is there any risk on that?
The only thing I can say is, CVVH is another added filter, and many of our patients were on CVVH in this neuroinflammation study. And when we tried to parse out between patients who were on CVVH versus patients who were not on CVVH, we didn't find a difference. But yes, in the initial phases itself, do you put them on, put on a filter? I don't know the answer to that. This is just such preliminary data, but it is, I guess, at least exciting data in my mind. I don't know if everybody thinks that way.
Interesting and exciting.
Yes, but there are lots of unanswered questions. And as I said, we have a few grant proposals, and hopefully the granting agency is going to think it is as exciting.
Okay.
Yes.
All the best.
Please.
One last question, ma'am. Do you think that like strategy in cardiac bypass in neonates, we have an alpha stat strategy and a pH stat strategy. Do you think that that strategy can help in putting same strategy in the ECMO also?
So definitely do that in terms of not the pH, at least for PCO2. People are very careful these days when they drop the PCO2, and Mark himself can speak to that. They published data on looking at change in PCO2. Mark, is that the, from the from the else?